Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Patrick. How are you doing today?
Hey, I'm great, Dennis. Thanks for having me.
Awesome. Well, since it's the first time on the podcast, would you mind doing just a quick introduction of yourself?
Sure, I'd be happy to. Like he said, I'm Patrick. I've been in the Army National Guard now for just about 20 years. I currently serve with a National Guard-based Special Forces battalion. I'm a battalion surgeon for them and flight surgeon. But every day as a civilian, I work full-time as a trauma and emergency general surgeon in Boise, Idaho, as well as run the surgical and trauma ICU for half of the shifts that I do at the hospital. So I'm happy to be here, really excited about it. I've been directly involved in pre-hospital care my entire military career, as I started out as a 68 whiskey once upon a time in undergraduate. So I enlisted first and then got into medical school. So talking about what medics do and how they can do it better is something I've been doing all my career, and it's what I love. So I'm glad to be here.
Well, awesome. So, but speaking of medics, if you want to turn a medic's stomach, is just mention, hey, your patient has been has penetrating abdominal trauma, and everybody, like, you just feel it in yourself. T-Tri-C, it's pretty basic. Try to stop whatever bleeding, cover it up, get some antibiotics on board. If you don't mind, let's walk through some of the common things, at least that I've seen when it comes to any of these treatments, and in that acute phase, like maybe some things that we should think about and we could do better, right?
Yeah.
And so I think number one is like the hemorrhage control. You can ligate, you can clamp. I've also seen people just grab intestine and spin it to get some kind of torsion, I guess, hemorrhage control. Are there any consequences to like clamping or spinning the patient's intestines around your finger?
Yeah, there's everything we do in medicine. I know it's a very good leading question. I know you understand that. Everything we do in medicine has consequence, right? Every treatment we choose is a risk versus a benefit. We always know that. And I think when you're dealing with intra-abdominal, especially mesenteric bleeding, those three choices you just gave all come with something. Mesenteric torsion, I would say, is a way to get hemorrhage control. I would say, though, as a trauma and emergency general surgeon, one of the biggest things I'm trying to avoid is widespread mesenteric ischemia. And so I would have to say that would be not a recommended method, simply because you are stopping the bleeding where you have the bleeding, but you're affecting a whole bunch more of that vascular distribution. So you're affecting a whole lot more gut than if you were to clamp or ligate. So let's say you're in the T-Tri-C phase, you're doing your march, and you find massive, or at least arterial hemorrhage, massive, not massive, whatever you want to call it. You come across bleeding coming from the abdomen because you're looking at the guts. I would say, in haste, the clamp, if readily available, is a great idea to stop that bleeding so that you can do the rest of your assessment and make sure there's not something else that's going to kill them, like an airway problem because they're actually unconscious and they're apneic, or they've got a pneumothorax and they can hardly breathe. I think a clamp is a very reasonable thing to do because it's hopefully fairly targeted, right? Like you fan out the mesentery or the gut, and you see a spot that is bleeding, and you say, I'm going to clamp on that. And even if in your haste you get like a bunch of that mesenteric fat and you get the vascular bundle and maybe you get another one adjacent to it, that's still a far less consequential thing than let's twist these guts at the root of their vascular supply so that this whole tree is no longer getting vascular supply. And mesenteric ischemia does kill people eventually. Now, that's that's down the line, right? You're looking at sepsis then, but that's something that it's a cat tough to put back in the bag, especially in the field.
Now, clamping, would you be fine leaving that clamp in place for a few days, or should we revise this, come back later, and ligate a little more accurately?
I think ideally you would ligate more accurately. Absolutely. In an ideal world where you are safe, you've managed the other things that are giving you the oh shit feeling about this patient, and now you're just like, I left some steel on that mesenteric, bleeding. Now you're thinking about what are the other things I can be doing. Yeah, I think like a targeted ligation is a great point. So what that requires, though, is a little bit of comfort with your anatomy, recognizing that there's a vessel in that apron or skirt of fat, right? And you would like to find the vessel that was broken and bleeding. And so you've got to maybe get a little bit of that fat out of the way, right? With another hemostat to try and get a little bit isolated to a vascular bundle of some sort. Does it have to be perfect? No. If you've got a suture of any kind, silk, vicryl, I don't care if it was a nylon. It doesn't really matter. If you've got something that you can tie around it, using the skills that you've hopefully learned on how to tie underneath a clamp and then release the clamp, yeah, that would be ideal. I think the other thing I would remind people is that anytime a vessel is cut, broken, torn, there's two ends of it, right? Don't forget that. It will likely bleed distally because we have an arcade that allows blood flow to back bleed from the other side. Even if you get the proximal side that was pressurized, there's a likelihood you're going to have some seeping from the other side. So just something to remember is all vascular injuries have two sides. But I think if you can tie them off, that'd be good.
So, we get them clamped. Hey, we're going to try and, at least in our mental note, hey, I'm going to revise this and ligate that later. Pour some water on it, maybe, and try to stuff that back in as soon as you can, right? Now, having done this, sometimes that bowel starts to expand, and that initial penetration might be smaller than what that intestine is now. Should I force it back in? Right? I have plenty of muscle. I can make it work. Should we leave it out and just keep it wet? Or should we open up that abdomen a little bit more, not go nuts with it, but open it up enough that I can now slide this inside? I'm sure context is everything, but what would drive your decision to do what?
I would go back to the risk of ischemia to try and make that decision. Like you said, I got plenty of muscle. It might not matter. Like you said, the bowel becomes more edematous depending on peristalsis and how big or small that abdominal wall injury or invasion was. You could get to a place where, stuff goes out of the bowel, out of the belly. And so, in your knuckle, you got a knuckle of intestine. It can come out, but it's not getting back in, it's not making that loop. And so then you have a kind of ballooning thing. The intestinal wall edema, that's going to take a little longer. I think we're talking hours at that point before you're going to have intestinal edema to the point where that becomes a really difficult problem. Maybe an hour or two before that really is noticeable. I would say that if you feel confident that you have your hemorrhage control, especially if you tied it, I wouldn't go shoving the hemostat inside the belly unless you had a big evisceration. If you had a very big laparotomy made by that penetrating injury and a live patient, let's add that in there, which, if you've got a laparotomy that big, how did they survive it? That's pretty remarkable, right? And why weren't they wearing their armor? But if you have those things, and I wouldn't be putting hemostats inside the belly. So you revise it to ligation. If you can put it back in, I would say yes. And the reason for that is ischemia. because like you said, it gets edematous, it gets bloated. Eventually, the vascular engorgement can cause that to become ischemic. And then you have an ischemic loop of bowel, which you aren't equipped to deal with in the field. That's a surgical problem that has to be removed, and then it's in discontinuity and has to be put back together eventually. Now, it can be in discontinuity for a period of time, but even more than a day. But it is a problem that has to be dealt with.
Okay. So we got a little bit of time to think about this, right?
Mm-hmm. Mm-hmm.
Maybe keep it wet, cover it to protect it till we can get out of the immediate area.
Yeah, I think covering it and keeping it wet, especially when you're going, if we're going to say that doctrinal, care under fire, field, tactical field care, casualty collection point, if you want to go through that doctrinal steps, you certainly don't have to worry about returning the viscera to the bowel, to the belly, until you're safe, right? Like you're safe, and long patient movement is now probably behind you. You're where you're going to be for a minute, I would say, is when you start to think, okay, am I going to be able to get this back in? Now, if it just tucks right back in easy, let's just say you have an evisceration that doesn't have blood boiling out of it. You don't see stool like falling all over the place. By all means, like tuck that thing in. If it's a quick finger, like Jack in the Box, putting Jack back in the box, go for it. I think that's a good thing to do. The bowel will be happier inside than it is outside, which makes the patient happier eventually. So, but if you have injury associated with it, get yourself to a controlled setting so you can start to evaluate, how am I going to go about this? Because you got to remember, is you're hoping you don't have a comatose patient, right? That's what you're hoping. Because if you have a comatose patient, then you have an airway that you've had to manage. Then you have more sedation needs. You got somebody bagging, or you're on the save too. Like everything escalates, right? The more decompensated your patient gets. So you're hoping they're awake with a little bit of chitlin squirting out, right? Well, that brings the pain and anxiety with it. So their abdominal wall is not relaxed. So if you've done a live tissue lab with a porcine or a caprine model, and you've done some evisceration and you've packed it back in, that is not the experience you're going to have with your 100 kilogram strapping dude that's alive and awake with his guts hanging out. His core is going to be tight, and it's going to be hard for you to convince him, hey buddy, I need you to breathe and relax your abdominal wall. That's a hard thing to ask him to do. So you go poking it back in, and you're going to find that the intra-abdominal pressure is working against you. It can be a problem. I have patients under general anesthesia, but not chemically paralyzed, and I can't get the bowel to stay back in. So give that some thought. Complete general anesthetic, intubated airway, propofol, gas, whatever, doesn't matter, but they are completely asleep and unaware of what's going on. But if they don't have muscular blockade, sometimes I can't keep the bowel inside in the operating room. So it's not, it can be a challenge, is all I'm trying to say. So you want to be in the right place where you can give it that thought and then see if it'll go back in. It just might not.
Is it worth expanding that hole? Let's say, because I'm not carrying paralytics. Yep. Like I can make somebody pretty deep, and I can maintain their airway, and I can maintain ventilation.
Yep.
I just don't have any paralytics.
Right.
My ketamine, that's not going to relax their abdominal wall.
Yep.
Maybe I give them some Versed and they'll relax a bit.
That's your best hope. Yep. If you can get them dissociated with ketamine, so like they're under like a true general anesthetic with ketamine procedural, plus some Versed to maybe do some of that relaxation, that's probably your best bet with what the special operations medic carries in their pharmacy. That's probably and then you're going to need a little bit of opiate, because even though they are asleep, their body experiences pain. So you might still need some fentanyl, right? Or if you have Dilaudid, just a little longer onset, right? Obviously. You might still need some opiate if you're going to do an abdominal wall procedure of some sort. So the question is, do I want to open it any further? That's a tough question. And that goes back to making a decision of how important is my intervention. If I believe I have hemorrhage that I'm not seeing, or I wouldn't open it to put things back in. Let's put it that way. But if there is no way, if I know that there's intestines bleed, these are hard decisions. You can tell I'm tripping over my own self on what to advise.
Let's say he's hemodynamically stable. We're in a safe place. He's got a nice loop of bowel sticking out. I can cover it up so he don't see it. I can keep it wet for as long as I have water. But like, I know this is going to be a giant pain in the ass, and that ischemia, like, it's going to set in, and he's going to have a bowel. I don't think it's called a perforation, but that wall is going to get weak enough that bacteria are going to come out. And I'm hoping and praying if I can get it in early enough, I can avoid that.
Yeah, no, perforation was the right word. Ischemia leads to perforation. You're absolutely right. And that's why people die from mesenteric ischemia, or one of the reasons, aside from systemic acidemia that can come with the ischemia. So that these are your decision trees, and I think you're thinking about it exactly right. Is where is my downstream effects that I need to address? I hesitate to advise that opening the abdominal wall is going to be a necessity, but it is a possibility. I'm not going to say I would not discourage it from being on the table. I would say that it's something you want to try and think about. How necessary is it? I think that ischemic knuckle of intestine is a pretty far down the line, as long as it's soft. Like, if you can kind of try to poke it back in, but maybe it just kind of sports back out, you probably aren't pressed to go doing that, because it's probably not going to get that vascular engorgement where the arterial pressure required to overcome that the constriction is enough that the blood goes into the intestine distally, but then the venous return can't overturn that abdominal wall, right? So that's where you get the ischemia, is probably that way. Now, if you have enough tension on that you're getting arterial insufficiency, you're going to know that this fast. It's going to be gray, and the intestine is so vascularly rich and also so vascularly sensitive that if you don't have arterial sufficiency, if you have arterial insufficiency to that knuckle of bowel, you're going to know as soon as you look at it, or within a few seconds. Like, it's 30 seconds, a couple of minutes, you're going to look at it and be like, that was pinker just a minute ago. Like, that's gray. That looks weird. Then if you can't put it back in right now, then you should open it a little bit. But less is more. Less is more. Because, again, Jack in the Box, right? That guy's going to bear down at some point. Even if he's comfortable at the moment, there's going to be a time where he says, oh, that hurts. And he valsalvas, and more comes out. It's going to happen.
Now, let's make this patient a little bit more difficult. Let's say he may have gotten a piece of shrapnel in the liver. Like, he's had some bleeding. We've had to give him, one unit of blood. Maybe we're thinking about giving him a second unit of blood. TRC guidance, you're targeting a systolic of 100, MAPS roughly 65, 70-ish. You're doing the permissive hypotension type resuscitation. You're purposely keeping it low. We can maintain that for a time. We can get walking blood bank. We can request for resupply. Like, there's options. Time will tell how many of those options you actually have available. But at some point, like, is there a consequence to just keeping them at this bare minimum for life when it comes to resuscitation?
Absolutely, there's a consequence. But there's also a consequence to driving them to normal blood pressure, systolic of 120, and then they're blowing any of the clot that might have happened in the hepatic injury. So I would say your only avenue with that patient where you suspect solid organ injury, liver, spleen, kidney, is permissive hypotension. And I would say, and I am a supporter of the JTS, 100% blanket statement. However, I would titrate to effect is what I'm getting at with blood pressure. If they maintain their mental status, if they maintain a radial pulse, I'm going to let that blood pressure be as low as I think I can without my own tachycardia overcoming me. Just because the vascular system of the liver is vastly venous. Okay. So the majority of your injuries to the liver are going to be venous, and it's coming off of the portal venous system, which is very low pressure, but it's high volume. So there is a reasonable chance to expect that to self clot and self stop. It's gain hemostasis. So if you can sustain permissive hypotension, I think that's the only strategy you have, and you judiciously work that walking blood bank to keep them lucid, keep them with obviously a palpable pulse. You got to have a palpable pulse, and that's kind of your best bet, because this is where it's scary for everybody, because there's nothing short of surgery that's really going to make a difference if this doesn't stop itself. And in the ivory tower, I get more blunt trauma than I do penetrating trauma, especially to the liver. But you'll be amazed at the grade of injury that I will see on a CT scan that I don't have to take to the operating room. So we're talking grade 3 and grade 4 hepatic injuries that don't require a surgical intervention necessarily. Where the body somehow, the capsule does it, and it's low flow, and we probably don't adhere to permissive hypotension as well as you guys are going to be able to do, because I've got so many people helping me that sometimes, like, if they don't see a blood pressure of 110, they get nervous, and so they're like turning more things on, and I'm like, hey guys, stop, let me make this decision. But so that's your move, is basically, yes, permissive hypotension. If you have time and you're sitting on this patient, then you need to get as many more data points for your prolonged critical care that you can. And probably the easiest low-hanging fruit would be to get a Foley and start recording hourly, or at least every 2-hour urine output. If you don't have the actual Foley bag, you just have the Foley catheter, you can clamp it and every hour open it into a cup, an Nalgene, I don't care, a water bottle, and start to estimate, are we getting 10 mils an hour? Are we getting 50? Are we getting 100? And that is another data point. One thing I always tell med students, residents, PAs that I'm working with, and medics, there's never one definitive gold standard data point in the ICU or critical care that tells me this is the problem and this is the move that we make. It's like all of them make a picture for you, and this is where repetitions for healthcare is so important. But like, you just get all of it together. Am I having a conversation with the patient like I was 30 minutes ago? Meaning, is their cognitive and their, are they dysarthric? Like, what are they talking to me? That's one thing to tell me. Are we perfusing the brain? Are we perfusing organs? And, their heart rate, their blood pressure, those are hard quantitative things. Got to know them to track the trend more than what is it right now? It's the trend, right? I'm sure you teach that ad nauseum at your refresher course in your lane.
Yeah. No, the way I put it is, all those things that told you this person is in shock, we need to start unwinding them. So if his mental status was your big clue, do you see it start coming back? Now, I also tell him, I don't need this guy solving puzzles either. I just need enough. And like, what's the right amount of fluid? Like, enough. That's all you want for this time.
Yeah.
Now the gut, just in case you didn't know, I'm not a doctor at all, but it gets its perfusion, or its perfusion is easily cut off by the body and sent to other organs, like shunted. Can I just maintain this permissive hypotension, even if I have the ability to give more blood for hours, a day, 2 days? What would tell you, like, okay, like, I think we're stable enough that we've made a clot, like we've stabilized. He is definitely a responder. Do I push it? Urine outputs on the low side, blood pressure on the low side, like everything's kind of, I wish it was a little bit better.
So the thing is that if you mostly have hemostasis, the body is going to start to self-regulate those markers for you. For the most part, we're talking about 17 to 40-year-old healthy men, most generally speaking, right? So we have physiology is the most favorable physiology that you're going to ever have most of the time. I know that we have Green Berets that might listen to this and say, dude, I work with the village elder all the time. I don't always have the military age male that pumps iron and drinks creatine. I know that. But for the most part, we're talking about taking care of the guy next to us in a uniform. That means a military age male that's at his prime of life. If you stop the bleeding and they stayed perfusing, and again, we talked about there's a spectrum of perfusing. If this thing is working to the point of I know who I am, that I got hurt, and that I know the people around me, like you said, they don't need to do calculus. They don't need to calculate the door charge or the charge to cut their railroad that they want to go cut or whatever. If we have those things, then it stays that way for a while. So we're like, man, I think it might have stopped bleeding. I haven't transfused him for an hour. I haven't transfused him for 2 hours. Then it's going to start, you're going to see those parameters get better. You're going to start to see the blood pressure creep up, heart rate come down. The heart rate's going to change sooner than the blood pressure, probably, most likely. The urine output is going to lag because without a doubt, the renal supply was going to be sacrificed for the brain and the heart, right? That's the order that the body's going to choose: the brain, the heart, then the kidneys, then the gut. But the gut and the kidneys are going to be close to each other just because of the risk, and the body somehow knows that. So I think if you get to a part where the heart rates come down, and then the blood pressure has just stayed the same, but then and everything else is the same, and you're seeing maybe this is where your urine output starts to matter to you a little bit more, then you're like, you know what? Let's give him another unit, but let's do it slower. Let's not do it in a bolus with this, with our EP cuff around it, squeezing it in. Let's just hang it up over him, give him it at the rate of, I don't know, 250 an hour. I made that number up, but something slower than squeezing it in.
Yeah. Then you can let it run and say, hey, I'm going to give, 125 mLs. I'm going to give a quarter of this bag, see what happens. We'll stay there for a little bit. Maybe we'll do it again. Yeah.
The other thing you could be thinking is, hey, I know I'm not getting to a surgeon for a day, 2 days, 8 hours, whatever it is. You could also, at that point where you're like, hey, physiology has settled, you can also just have him hydrate. Yeah. Like oral hydration at that point could be the right answer, especially if we're talking about, I don't think he's got a gut with holes in it because he's just not showing, he doesn't have peritonitis necessarily. You're hoping, right? You could have him, you could consider either crystalloids, which I'm going to take that back. Crystalloids are evil in the bleeding patient. If you want to let him hydrate, you might get your bang for your buck, might be the most efficient to help with, a little bit of urine output, and maybe the blood pressure comes up a little bit better, because that could be a reasonable thing to do if you're a few hours into it and you're not going to surgery anytime soon.
Yeah, he's auto-resuscitating, so he's pulling fluids out of the cells to stick it in the vasculature.
That's right.
So we started kind of getting into maybe a longer term after the T-Tri-C, doctrinal phase, like, hey, we're we're stuck here and we're going to have to hold on to this dude. So, we have some scary things potentially in our future, right? Peritonitis, that's never fun. Infection, Ileus, potentially some kind of abdominal compartment, depending on how crazy you went with the fluids, or could just be tissue damage, right? How do you, once you've made it past that couple hours, like, what things are you scared of first? How do you start mitigating those?
Sure. The things I'm scared of first is of course, it's continued bleeding. You're not always going to know because you don't have a CT scanner. You're not doing a laparotomy. You're not always going to know. So the first and foremost, as we already talked about, you got to start settling in for critical care for the long haul. And that comes to where that PFC card that is circulating out there is a really good idea to start putting your little, arrows just so you can see the systolic blood pressure going up and down, see the heart rate going up and down, and then you're tracking your urine output. Those are really the things that are going to kind of show you, is this getting better, getting worse, or are we staying the same? That's about the best you can do, is better, worse, staying the same. And so after that, you start to wonder about contamination and infection. In a trauma laparotomy, for me, it's hemorrhage control, and then contamination control, and then reconstruction. That's how I go through a trauma laparotomy. So that's in that order. So you're doing the same thing. I've done what I can for hemorrhage control. It's a black box in there that I don't necessarily get to enter or get to help with, but I've resuscitated. I think they're now acting hemostatic from a critical care viewpoint, gathering as much info as I can. So now I've got to think about contamination. You may not know if the evisceration was small, or you don't know, you got multiple like little shrapnel penetrating wounds, so you don't know how far they got in there. You don't know what it is. But you probably should assume you have a hollow viscus injury, meaning stomach or intestine or colon, right? One of those three things probably has a hole in it. You should assume if you have a hole in the abdominal wall between the nipples and the pubic bone, if there is a hole, you should probably assume you have a hollow viscus injury in the absence of the ability to look. And I think empiric antibiotic coverage is a good idea. It's the best you can do. And I know that most kits, usually people leave, most Medix pharmacy has a antibiotic or two in it. I know the JTS or the T-Tri-C standard is ertapenem is the preferred one, but it's also very expensive and isn't always available when we try to order stuff for teen guys. So the next one that usually gets chosen, because it's so much cheaper and it's so much more ubiquitously available, is ceftriaxone.
Yeah,
Great
that's
choice.
The one that's recommended now.
Yeah, if it's what you got, that I totally agree. What other things might you have? You might have Zosyn, which is another expensive one that you probably don't have. Let's be honest. And then the other one would be Augmentin, which is almost always only oral, but I guess if it's what you got. But no, ceftriaxone's great. I would add, ceftriaxone has a very good gram-negative bacteria coverage. Some gram-positive, but it doesn't cover anaerobic contaminant microbes. So if you had Flagyl, throwing Flagyl on top of ceftriaxone gets you both gram-negative and anaerobic coverage, which is basically what you need for enteric injury, enteric contamination. That's what you can do. But I recognize you might not have brought IV Flagyl. Oral Flagyl is just as bioavailable as IV. But if you have concern for gut disruption, maybe that's not the best plan either, right? So it's all doing your best. You do your best with what you got. Ceftriaxone's a great choice. It's also a 24-hour drug, right? So you give it today, and 24 hours later you give another. So it's a resource smart drug. I mentioned Zosyn, which is piperacillin tazobactam. That's an every 6 or 8 hour drug. So that's not very advantageous to the field medic, right? So So ceftriaxone is a good choice. If that's what you got, you should put that in there. I agree.
Now,
I think so.
As long as I keep up with my antibiotic regimen, does it matter that he's got stool and French fries and whatever else is floating around in his intestine?
It does. It really does
Damn.
matter. It really does. And it's only going to stave off systemic sepsis. It's not changing the contaminant burden. And unfortunately, I don't think I can recommend that there's anything else you can do in the field. Until we have shifted our doctrine or our guidelines to the 18 Delta and the Whiskey 1, where we are teaching them to do laparotomies in the absence of a surgeon, which we aren't currently. I've been to plenty of SOMA conversations where we're talking about should they be taught damage control laparotomy. It's a heat. Surgeons on both sides of that argument get pretty intense about it. I've observed as a young surgeon listening to them. I have my opinion. I'm not going to come in on that right now because, I just don't think that's what we're doing here. But so until we have that as an established thing, there's not much you can do besides that antibiotic if you've got spilling stool inside the belly. Unless your evisceration was big, right? If the injury pattern gave you the laparotomy, well, then the damage has been done, and you could run the bowel, is what we would call it, and find that contaminant source. And then if you could try to sew it closed for lack of anything else. You've all been taught to suture. I know that you can run a suture, use a suture. You can whip stitch that close and tie it and hope that it helps. And you could soak, you could try to rinse it out a little in the belly. But I'll be honest, you will be shocked at the amount of volume that goes into an abdomen if you are literally just dumping it into the abdomen rather than just trying to rinse off the intestine that's like in your hand. I often use 5-6 liters of fluid when I'm doing a decontamination lavage of the abdomen. So since we all, at least I shouldn't say we all, since we've poo-pooed on crystalloid for shock resuscitation, hemorrhagic shock resuscitation, medics are carrying smaller and smaller volumes of crystalloid all the time. I wouldn't be surprised if medics won't carry more than one 250 milliliter saline bag, just because they use it. All they're going to use it for is mixing medicine, and that's it. And I support that. One of my passions is blood resuscitation and hemorrhagic resuscitation. It's actually, I'm the transfusion committee chairman at my hospital. Like, this is what I try to focus on, and I try to teach the gospel of this to the civilian practice. I don't resuscitate with saline. I don't give LR to a patient that's bled. I just don't. I will tolerate shockingly low blood pressures before I will give crystalloid. So I get it that medics don't carry much of it.
I think in the aid bag, that's perfectly reasonable. In the truck or in the clinic, you're going to have to try harder to convince me that having one 250 bag in all of your clinic is
yes.
Okay.
Yes, I was referring to the bag.
Yeah,
You're absolutely
I'm sure.
right. You're absolutely right. Because we don't just treat trauma, right? We don't just treat hemorrhagic shock. Yeah. We do need crystalloids for certain things.
Okay. So as long as we keep up, at least we'll avoid sepsis, which is not a small deal. But there's going to be some kind of lower infection or local infection.
We're going to
stave whomever
off.
Else.
We're going to stave off systemic catastrophic sepsis. Yeah. We're going to delay it. We're kicking the can down the road
until I can get them to you.
Yeah.
Okay. Things like, is it worth, even just for wound management, irrigating?
I think it's, if you have visible soiling right in front of you, I think that is worth it. Yes. I'm just trying to, all I'm saying is be realistic, that if you had spillage of stool inside the abdomen, it takes a hell of a lot of work to have controlled that contamination. But absolutely, if you have a small knuckle of bowel hanging out on top of the abdomen, clean things up. Sanitation helps. There's no reason, we all believe in germ theory now. 150 years later, you should do something if you can. Absolutely.
Nutrition always comes up. And now if we're talking about abdominal injury, it's kind of hard to feed somebody when their gut isn't working. I listen to their abdomen. I don't hear any bowel sounds. They're not passing gas. They're not giving any stool. Maybe they're giving urine output, but as far as the gut goes, nothing's really happening. Is it okay to just go ahead and feed them anyway, or is this actually really, really dangerous?
Yeah. So you're describing Ileus, right? Obviously. In this patient population, a concern for Ileus wouldn't stop me from allowing them to have nutrition. But if my spidey sense tells me I have discontinuity of the bowel, then they need to be NPO. That's just blanket statement. They have to be. But you don't have a CT vision, right? CT scanner vision. So if you have penetrating trauma to the abdomen, I think unfortunately, initially you're going to have to assume they have bowel discontinuity and say they're NPO. If you're sitting in an abandoned building for going on 2-3 days and they haven't developed peritonitis and they're hungry, yeah, you should let them eat. And I said 2 or 3 days. I made that number up. It's not, there's nothing magic there. It's not like a checkbox that I want people to write down. I'm just saying, like, if they haven't developed peritonitis and you don't know when you're getting out of there, they've got to have nutrition. It's just got to happen. So at some point, you've got to say, man, I'm pushing on that belly. It's staying soft. They're stable. They're awake. And they're saying, yeah, I could eat. Yeah, let them eat. I think you've got to. You just got to. Because things start falling apart if nutrition falls apart. We call it surgical nutrition. It's a topic we've been trying to work on for a decade or more, 2 decades, is getting our patients more nutrition sooner than we used to. We talk about it all the time in the OR, in the ICU, about these polytrauma patients that are going to the operating room every day for days and days, and anesthesia wants them NPO for 8 hours, and we're trying to get them, but their sepsis gets worse if people aren't, adequately nourished. Things just fall off the rails. So at some point, you've got to take the leap and say, you know what? Here's your beef stew from the MRE. Try it out. There's no magic decision on how. But your abdominal exam is huge. That's important. If they're not developing sepsis and they're hungry, they're probably okay to eat it. Especially if they're saying, hey, I'm kind of hungry. Now, the Ileus thing is going to be, they're not going to feel hungry, probably. But you know what? If we're a couple of days in and they don't have peritonitis, they should probably be fed and see how it goes. And they don't have to finish what you give them, but they should try the waters out. As far as general surgeons go that work on the gut, I'm an aggressive early feeder. There are surgeons that are more conservative and wait a little longer. And I don't think either one of us is always right or always wrong. But I'm an early feeder after surgery. So in trauma with unknown injuries, I'm probably going to be on the earlier side as soon as my exam starts to feel reliable and reassuring.
Let's say we have that patient. He's saying, like, I think I could eat. I give him food. He swallows it down. Is there any concern that would tell me, like, hey, we should stop, or at least for this feeding, like, should I give him a period of time?
It's going to be the obvious thing you do with your kids that are sick, or anybody. This is common sense. I don't think there's any nugget or insight from a surgeon that is special here. If they start to feel bloated or nauseated, or they throw up, they're done. I know that seems really, that I don't mean to insult anybody, but it's about as simple as that. When I first introduce food back to a patient, I literally say, like I said, again, you'll have surgeons that have varying practice patterns. Some will always reinitiate enteral or oral feeding with clear liquids only. and they'll see if they tolerate that for a day. And then they'll go to what we call full liquids, which is like milkshakes and protein shakes and puddings and things that are liquid or solid liquids, for whatever that means. And then they go to regular food on the third or fourth day if it's going well. I'm, again, a little bit more aggressive, and it's either I'm NPO or I'm regular diet. That's what I do. And I put that tray in front of them and say, this is not a prescription or a challenge. If it looks good, try it. If it tastes good, eat it. If you look at it or you take one bite and you're like, no, then push it away and be done. And I would continue to go that way. If they vomit, then take it away, right? There is the odd person that like has no self-inhibition, and they're going to take that first tray and they're going to like double fist it, and then they're going to vomit, and everybody wonders, well, why'd you feed them so soon? Well, maybe if they hadn't gone like hog wild on it, they wouldn't have vomited. So it takes a little bit of, hey, just take it calm, take it slow, but follow your body. That's how I approach it.
Peritonitis, we're maintaining this patient. Their pain, the analgesia requirements are kind of going up. Maybe they're obviously their abdomen hurts. Maybe it's kind of rigid. Like what can we do? We've been staying on our antibiotics. Like we've done all the right things, but why did it go wrong?
One of two things: continued contamination, or just contamination period, got a hold of them, or ischemia of something. And then they developed peritonitis. And unfortunately, you've done everything you could do. And aside from more analgesia, there's nothing more you can do until they can get an operation. And that's the sad reality, is a patient with peritonitis needs a laparotomy. And that's about it, besides, your sepsis bundle type stuff, right? Which is broad spectrum antibiotics, aggressive resuscitation, and analgesia. That's the sepsis bundle. You've already done it. You've been doing it. You're watching their blood pressure. You're watching everything. You've given them broad spectrum antibiotics. You're on schedule with it. That's where it's sad. And that's where what your operational environment kept you from getting evac earlier. I doubt the call and say, hey, I've developed peritonitis. My patients developed peritonitis. I don't know if that reprioritizes your ability for evac or not. You and I, probably not. You and I off of recording talked about the constant conversation about evac times are not getting shorter. I just came back from UCOM supporting the Ukrainian thing. Don't get me wrong, I was outside of Ukraine. Don't start rumors to anybody. We were just training people outside of Ukraine, but the conversation is constant about how long their evac times are because of the drone warfare environment. So, it's not going to change. So I don't know that the phone call, hey, now they have peritonitis, changes your situation, but that's the best you can do. Unfortunately, the best you can do is calling back up and saying, hey, he's now got peritonitis. Blood pressure is still the same. He got a fever. Because the next phone call is going to be his heart rate's 140 and his blood pressure is 90 because he's in florid sepsis. And that's what it is.
I mean, that's when you start doing telemedicine. Like, what other antibiotics can you ship me? What can I do early to help maintain longer, if anything?
Yeah. And at that point, it's just sepsis care. You're just heading off sepsis care. And so making sure you've got, I'm struggling to give you much more. And that's the sad part, is peritonitis is just a bad sign because sepsis comes behind it.
So other than peritonitis infection, are there any other major concerns that I need to watch for that are going to develop later?
Earlier, you hinted at the possibility of like an abdominal compartment syndrome. I would say, yes, it's absolutely possible. Sorry. It's absolutely possible. It's also very unlikely when you're doing a whole blood resuscitation of a patient. In my career, I'm not old and I'm not super, super young as far as a surgeon goes. But but the timing of my short career has been a very interesting time in resuscitative medicine, where I have seen high volume crystalloid resuscitation and I've seen only whole blood resuscitation in my career. And I'll tell you, abdominal compartment syndrome is almost vanquished in the era of whole blood resuscitation. It's almost not a thing unless you're dealing with a pancreatic injury. And that's a whole nother set of pathophysiology, problem set that is very complex. And I don't even know that I'm an expert on it, even though that I'm the one that has to deal with it. But that can cause compartment syndrome in a different pathway of just the inflammatory process is just so tough to stop. But basically, if you're talking about hemorrhagic resuscitation with some bowel injury, if you don't have gross contamination, terrible, terrible contamination, and you're doing whole blood resuscitation for the hemorrhage part, your risk of abdominal compartment syndrome is very, very low. It's high volume crystalloid resuscitation that causes uncontrolled bowel edema, intestinal bowel edema, bowel wall, that causes that possibility of compartment syndrome to start to become a problem. I think we should briefly talk about what does abdominal compartment syndrome look like? How do you start to see it? And I think all of our listeners probably have an idea of what it is, and they know it's scary and bad. But let's just say, what are we going to start to see? It's intra-abdominal hypertension with end organ dysfunction. That is the definition. You don't have abdominal compartment syndrome without bringing those things together. You can have a tough, rock hard abdomen, but if for some reason they're still not in progressive respiratory failure or progressive renal failure, you probably don't have abdominal compartment syndrome. You might just have a rigid peritoneal abdomen. That sucks, but it's probably not compartment syndrome. People will talk about getting a bladder pressure. That's outside of your equipment scope as a prolonged field care medic. And it's also not diagnostic unless the patient is neuromuscularly blockaded. So by definition, your bladder pressure measurement doesn't matter if they weren't paralyzed. You and I already talked about you don't have paralytic. You're not going to have the dynamometer that's going to get a bladder pressure anyways. So you're stuck with a physical exam, what my hands show me when I touch the abdomen, and then what all my other critical care data points are. So if they have a progressively distended and firm abdomen, and all of a sudden you're noticing their respiratory effort is different, more shallow, more rapid, or you're seeing a sharp drop-off in their urinary output, that's when you start to worry about compartment syndrome. What can you do about it? Well, if earlier on in the course you had an evisceration and you managed to push it all back in there, and maybe you even did maybe you were really gee whiz and you saw once in a textbook where old school surgeons used to do temporary abdominal closures by opening up a saline or LR bag and sewing it or stapling it to the skin. Maybe you saw that and you're like, I'm going to do that. Bogota bag. Exactly. I was going to refrain from using that name, but yes, the Bogota bag. If you were gee whiz and had the time and you did that because you had so much guts hanging out, number one, I applaud you for doing it. That's the right move. But all of a sudden you've got this progressively distending thing. Their urine output has dropped off and now they're starting to not breathe well. You probably have abdominal compartment syndrome and you got to pop the hood. You got to take your Bogota bag off. Now, if you don't have a Bogota bag to relieve, then we're back to the same kind of debate about, well, should I widen my abdominal wall injury to help me put things back in? Now we're asking the question, should I widen this to help them come back out? We're kind of veering towards that. Well, should we be teaching advanced combat medics to do laparotomies or not? We're going back to that to that debate about that. I think this is where telemedicine is important. I hope that they get you in touch with somebody like me, and we could decide together so that you're not sharing that burden of decision making. And then maybe I can give, if we decide to go for it, because we got no other choice, then we can decide. And then I can walk you through some pro tips on how to not make another problem while you're doing it. Because you got to remember, you've got guts that want out. So as soon as you start making an incision, what keeps you from getting that knife and slicing a bunch of them open? Because you've never done a laparotomy before. It's scary. Like the first time, I mean, you guys are all badasses. You're not scared of much. But I would hope that your butt would pucker a little bit the first time you're doing a laparotomy, and it's not in an OR with me, in a training environment. I would hope you still have a little bit left in you to be a little bit scared when that happens. Doesn't mean you couldn't do it and we can make that decision together. But you got to think of, okay, then what's my third order effect of how am I going to manage this patient with this wide open going now? Are they staying conscious? Am I going to control their airway and sedate them now? How am I going to contain? Hypothermia is now a massive problem, right? Because now you have their entire mesenteric, their gut exposed to the atmosphere. That's a huge ability to lose evaporate all of it. I mean, you might just watch their soul go floating right out through the window of the building that you're in. Quite honestly, it could be that fast. I mean, it's like you just watch their soul leave. I mean, if they get cold that fast. So there's multiple layers to the decision you're making. Abdominal compartment syndrome is a lethal problem if it develops in a prolonged care. That's a big deal.
I guess when it comes to abdominal trauma, maintaining it over time, is there anything else that, any other landmines I need to watch out for?
No, I think we've really covered the gamut of what could be expected to happen and or to manage. Hemorrhage, contamination, which leads to sepsis. Those are your things that you've got to deal with. Reconstruction's a several days away problem, not an issue. So if you can control hemorrhage and contamination early on, I don't know if I would imagine the surgical portion that 18 deltas get when they come back for SOCMOS SC, what's it called, SFMS or something like that, they might get a little bit of OR time and at least handle some intestines. So they might feel a little more comfortable with like, hey, there's the hole in the intestine. I could clamp here and I guess cut this out. I don't know, maybe they could get creative. But basically, if you can control hemorrhage, you can control contamination, you've made a huge step. Again, we aren't teaching laparotomies to advanced combat medics, so we're talking about the bowel that's already out right in front of you, right? So do those things if you can, and then you're hopefully preventing sepsis, you're hopefully preventing exsanguination. We've talked about solid organ injury and hoping that permissive hypotension will get you through. It's the only option you really have, because again, we're not doing laparotomies and packing livers in the field especially. So, and then it's just resuscitation and never abandon your PFC critical care skills, which is chart their vitals. If you can get their urinary output on a regular basis, do so. Keep talking to them, or if you've decided you have to sedate them, you've lost that measure, all the data points you can get is what you want. And then you the little nursing things, clean them up, pad them, turn them frequently, every hour or two, leave some pressure points on their coccyx, on their shoulder blades, whatever you can do. And your knuckleheads and your squad can help you do a lot of this stuff. It's not all on you. You can sleep.
Well, awesome, Patrick. Thank you for jumping on.
Yeah, it was a pleasure and an honor, and I appreciate the opportunity. If I can ever be helpful to anybody in the community, I want to. The medics I work directly with have me on signal, and I always say I will answer the phone 24 hours a day if I can. But I hope I can be beneficial somehow to the community.
Awesome. Well, thank you. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.